welcome to Breast Cancer Breakthroughs. The 2024 American Society of Clinical Oncology meeting, or ASCO, just took place in June. This annual meeting convenes over 35,000 oncologists, scientists, and patient advocates to discuss the latest practice-changing advances in cancer treatment. Improving personalized medicine was a consistent theme throughout the meeting. This means ensuring that patients are getting the right treatment for their cancer at the right time. Not only does this improve outcomes, but it leads to better quality of life as well. In this episode of Breast Cancer Breakthroughs, we'll speak with Komen grantees Dr. Tara Ballinger and Dr. Pedram Razavi about the most important takeaways from the 2024 ASCO annual meeting and what they mean for patients. We heard several important updates on early breast cancer at ASCO this year. One of the most important studies looked for solutions to reducing toxicity from some types of chemotherapy for Black women. This study, called EAZ-171, was conducted by Komen scholar Dr. Brian Schneider and presented at ASCO by Komen grantee Dr. Tara Ballinger. We asked Dr. Ballinger to tell us more about the results and how this will impact chemotherapy personalization for Black women.
So EAZ-171 was a trial specifically focused on Black patients with early stage breast cancer. We know that Black women with early stage breast cancer have worse survival from their breast cancer, also higher rates of toxicity, namely peripheral neuropathy. Peripheral neuropathy from our taxane drugs like docetaxel or paclitaxel impacts quality of life, but it's also the primary reason for dose reductions of therapy, so it can impact survival as well, particularly for Black patients, as they tend to get higher rates of neuropathy. So EAZ-171, we enrolled only Black patients in order to look for genetic biomarkers of who might be at higher risk for neuropathy, and also to look at whether paclitaxel or docetaxel might be a better taxane drug with regard to neuropathy and dose reduction specifically for Black patients. So in the trial, again, we only enrolled Black women, 249 women enrolled on the trial. We were not able to validate the genetic markers of neuropathy, but we did find that there was significantly less neuropathy and less dose reductions with docetaxel compared to paclitaxel, suggesting that that should potentially be our preferred taxane specifically for Black patients with early stage breast cancer. And then I think more broadly, not only is that going to impact our chemotherapy choices, but also the trial taught us that can and should be designing trials better for to evaluate disparities in patients who are typically underrepresented in our trials.
Dr. Ballinger also gave us some insight into other advances in early breast cancer she saw at ASCO.
In early stage breast cancer, there was a study presented at one of the rapid oral abstract sessions where they were using a large national database to look at outcomes for patients with estrogen receptor low breast cancer. So typically, we say estrogen receptor positive patients who are eligible for trials have 10% or higher estrogen receptor positivity. And then we say negative is 0%. So then these patients with tumors that are 1 to 9% get left out of a lot of our research. So this study, they looked specifically at those patients to determine whether or not they benefit from receiving adjuvant anti-estrogen treatments. And this has been a question that comes up a lot in clinic and comes up a lot for patients. Am I really going to benefit from this drug that has potential toxicities that I have to take for years and years? And the trial suggested that yes, those patients with estrogen receptor low tumors are benefiting from adjuvant anti-estrogen therapy. So that study has already helped me have discussions with patients about the risks and benefits of doing endocrine therapy when their tumor just had a little bit of estrogen expression, because that's a hard spot to be in. So I think that study was really important. Also, in early stage breast cancer, we heard results of the A-BRAVE study. So this study looked at doing immunotherapy after surgery for patients with triple negative breast cancer. The patients in that study didn't get immunotherapy as part of their upfront chemo. Right now, it's standard of care to give immunotherapy during upfront chemo from the Keynote 522 study. But what we haven't really known is if you respond really well to that immunotherapy, do you still need a year of immunotherapy on the back end? So the A-BRAVE study was kind of interesting because doing that immunotherapy after surgery did not improve disease recurrences, but there is this trend toward improving overall survival in that study. So I don't think it changes our practice, but it gives us a little bit more information about who really needs to get immunotherapy. Do we need to give it to people that didn't get it up front, et cetera?
There were a lot of exciting advances in metastatic breast cancer research this year, particularly for those with estrogen receptor positive breast cancer. One of the most talked about presentations was the Destiny Breast 06 trial. Dr. Ballinger told us more about this trial and other trials that she was excited for people with metastatic estrogen receptor positive breast cancer.
I think the most impactful study presented at ASCO this year in breast cancer was probably the Destiny Breast 06 study. So this study used a drug called trastuzumab deruxtecan, or Enhertu, which is an antibody to the HER2 receptor on breast cancer cells. And then it has high doses of chemo attached to it that get delivered directly into the cancer cell. And we've previously had approval to use that drug for HER2 positive breast cancer and also HER2 negative breast cancers, like triple negative or hormone positive, that have a little bit of HER2 expression or HER2 low, but only in later lines of therapy. Destiny Breast 06 studied trastuzumab deruxtecan versus chemo after patients had progressed on endocrine therapy for hormone receptors. So this would be their first line of treatment. It improved progression-free survival over chemo, and there's a trend looking like with more follow-up, it's going to improve overall survival as well. So this is important for a couple of reasons. One is we can use the drug earlier now for patients for whom that's appropriate, but also the study looked at something called HER2 ultra low. So these would be tumors that were previously HER2 zero, no HER2 expression at all. But if there's even the tiniest bit, we now see that patients benefit. So this is almost 90% of the patients we see who are benefiting from this drug. And we need to work with our pathologists to figure out how to test for this well. And already this week, coming in the weeks off of ASCO, I've had to request multiple of my patients' tumors be retested for this. So I think it's going to impact a good majority of our patients with metastatic breast cancer. We also, I think in hormone receptor metastatic breast cancer, we have a lot more expanding options. At ASCO, we also heard the Innovo 120 study, which uses a drug called inavolisib that targets PIK3CA mutations in hormone receptor positive breast cancer. That was a positive study. So was PostMonarch, which looks at patients continuing their CDK4/6 inhibitors after progression on a CDK4/6 inhibitor. So now we get more and more options for hormone receptor positive metastatic breast cancer, and we just have to work on how to sequence them and how to individualize kind of who needs what when.
As Dr. Ballinger explained, more work is needed to better individualize these exciting new options for patients. Komen grantee Dr. Pejam Razavi also attended ASCO and saw that advancement is needed to personalize treatment, particularly for antibody drug conjugates, or ADCs, like trastuzumab deruxtecan. In particular, he explained that developing new biomarkers is crucial to helping oncologists select the right drug for the right person. He also mentioned that some of the traditional tests used to measure biomarkers have not kept up with the latest developments in research.
I think we're getting to the point that selecting between the ADCs would need some form of biomarker. And there were some good studies and some good presentations at ASCO just highlighting the fact that we need better biomarkers. We need to be able to select between which one of these do I need to ADCs? Should I offer the patient? Should I offer a HER2 ADC with this payload? Should I offer a TROP2 ADC with a similar payload or different payloads? Should I go for another? So there was a whole series of presentations just highlighting the fact that we need better biomarkers for selection of these ADCs. At this point, we are just giving them crudely with this tools. So for example, for HER2, with a tool that was developed for HER2 positive breast cancer patients. This IHC that we use to identify HER2 expression was designed to identify patients with HER2 dependent high HER2 amplification. It's not designed for this lower spectrum of HER2, similarly with the other ADCs. So I think, in my mind, there is an absolute need for biomarker, and that was highlighted very nicely in multiple studies.
Another area of treatment personalization Dr. Razavi was excited about was advancements in liquid biopsies. He discussed a new analysis of the monarchE trial presented at ASCO that looked at how well circulating tumor DNA, or ctDNA, could predict outcomes of the patients enrolled in the trial. You can learn more about the monarchE trial by checking out our last episode of Breast Cancer Breakthroughs. He explained that finding ctDNA in a patient's blood was a sign of poor prognosis, whereas patients whose ctDNA became undetectable after treatment had better outcomes. He was optimistic about what the results could mean for personalizing treatment in the future.
I work on liquid biopsy and cancer genomics, so there were multiple good studies actually presented in the liquid biopsy, providing some options and also some future directions how the field should move. The monarchE clinical trial, as you know, is a positive clinical trial in early stage breast cancer, resulted in approval of abemaciclib in high-risk patients. They did a ctDNA analysis of patients who received abema versus controls, and then the patients who were ctDNA positive and remained positive had a significantly worse outcomes at the initiation of this study, at the landmark analysis that they did, compared to the patients who were ctDNA negative at baseline. This is one of the very few and first ctDNA analyses in a large prospective phase 3 trial showing the same thing. There were a group of patients who cleared the ctDNA on the drug. We don't know if it was on abemaciclib or on the control arm. Regardless of that, there was a group of patients who cleared the ctDNA. Those patients did better. There were a group of patients who remained positive. They were the ones who unfortunately did worse. So there were multiple caveats the way that we should interpret these results, and we should look at these results. But overall, very promising data to me and for the field, showing us that we can potentially use this ctDNA data in the future to stratify the patients, to identify the patients who are at higher risk, even monitor the patient's response on adjuvant treatment when they don't have anything else to measure, to see if they're responding to this treatment or not. We are subjecting these patients to 2 years, maybe even 3 years of adjuvant therapies in addition to what they receive as adjuvant endocrine therapy. And we need to be sure that this is actually effective treatment for the patients. I think this was very promising data. I would love to see more of such analyses in the future ASCOs and future conferences.
Overall, Dr. Razavi and Komen were thrilled to see the progress made at ASCO this year.
I'm excited. It's a good time to be a breast oncologist. Specifically, we are during that time that we have every year, we have interesting drugs being approved. We have interesting drugs that are, and very good drugs that are in development in phase 1, phase 2, and some of them are entering the phase 3 and will be available to our patients. Every time we have better tools like liquid biopsy, other biomarkers that we can use to identify the patients better, stratify them, and offer them more effective treatments as we see them in clinic. So I think it's an exciting time.
Dr. Ballinger also stressed the important part that patients play in the research process and in planning their treatment decisions.
I think our patients are such important part, or maybe the most important partners in the research that we do. And having those research results disseminated to patients really helps us understand how to put them into practice and what the barriers might be to actually delivering those research updates in our clinic. And I think hearing the patient perspective, sometimes we confuse safety of a drug with the tolerability of the drug. So it's always good to hear the patient feedback on all of that, and then have the patients come back to inform what our kind of next research priorities should be in that space. But then I think too, for an individual patient, being an important advocate in their own care to then bring those research updates up in clinic and ask how that might impact their care, and just kind of get a discussion started with their physician about what that means for them personally, and just a discussion about clinical trials in general and what they may be a candidate for down the line as well.
Thank you all so much for watching. We hope you've come away feeling empowered to work with your doctor to make breast care decisions that are right for you. Here at Komen, we are committed to bringing you evidence-based information to empower you as you navigate your journey with breast cancer. Don't forget to sign up for reminders for breast cancer breakthroughs. We've linked the homepage below. And finally, if you enjoyed today's episode, please take 2 minutes to fill out our short survey, which is linked in the description below.